So in this chapter, we are going to be looking about understanding heart murmurs. So murmurs can happen, or valvular heart disease can happen to any one of our four valves, our mitral, tricuspid, aortic, or pulmonic valve. The special thing about our mitral valve is that it is bicuspid. It's the only valve with two cusps. Every other valve has three cusps. So the classification of our valvular heart disease depends on the valve that is affected, or if there's multiple valves, and the type or the functional alteration. So whether it's stenotic or stenosed, or whether there's regurgitation. So clearly if there's stenosis, it's a smaller opening. And if there's regurgitation, it means that the blood is backflowing either into the atria or into the ventricle, depending again upon the valve that's affected. So in stenosis, there is a constriction or a narrowing. So the valve opening is smaller and forward blood is impaired. We can measure the degree of stenosis based on pressure differences. So this is obtained in the cath lab, really, to see those different pressures. Regurgitation is also referred to as incompetence. So when you have an incompetent heart valve, it means that you have regurgitation, or an insufficient heart valve, it means regurgitation. So sometimes those terms are used in place of regurgitation, but you don't have complete closure of the valves and it results in a backflow of blood. So the first valve dysfunction we're going to go over is mitral valve stenosis, which is mainly caused from rheumatic fever. And since we don't really have a lot of rheumatic fever cases anymore in the United States because of antibiotics, we really don't see mitral valve stenosis to the degree that was once upon a time. So rheumatic heart disease is an inflammatory disease of the heart that is caused from group A strep, or untreated strep throat. And then what happens is we wind up getting adhesions that build up or scarring of the valve leaflets and chordae tendineae, which leads to this very stenosed valve, or the valve that's unable to open. So what happens in the body because of this stenosis? So clearly we get a decreased blood flow from the left atrium to the left ventricle, but the atria still tries to overcome that amount of pressure. So we wind up with the left atria hypertrophying or enlarging, and then also that blood winds up backing into the pulmonary vasculature. So we are at high risk for AFib with mitral valve stenosis just because of the hypertrophy that happens with the left atrium. And this is just a nice little picture of what that looks like, just to give you a visual. So as you can see, my preload is really low, or the amount of blood in my ventricle, and then you can also see how that blood would back up into the lungs. But again, that left atria will hypertrophy and then put us more at risk for atrial fibrillation. So how does this look? So some of the clinical manifestations for mitral valve stenosis include exertional dyspnea, and this is secondary to decreased lung compliance because that blood winds up damaging some of the pulmonary vasculature. A very loud S1, because S1 is closure of the mitral and tricuspid valves. A heart murmur. Fatigue and palpitations could possibly be from atrial fibrillation. That's very common in this. Hoarseness and hemoptysis. Those are caused because as the left atria hypertrophies, it can press on the laryngeal nerve, causing voice hoarseness. Chest pain can be related to decreased cardiac output that we get because, our left ventricle doesn't have as much stroke volume because the opening from the left atrium to the left ventricle is tightly closed, right? So we don't have a lot of volume, so decreased cardiac output. And seizures and stroke, and that would be secondary to emboli from our atrial fibrillation. So we do have to take into consideration the symptoms that we would also get from AFib, since this is a common complication or common thing secondary to mitral valve stenosis. So for mitral valve regurgitation, Valve function really depends on whether or not many of these structures have a problem or just a few of these, but any of defects in any one of these four things listed can cause regurgitation. Damage to those structures can be caused by an MI, can be caused by rheumatic heart disease or rheumatic fever from untreated strep throat, mitral valve prolapse, which we talk about in just a second, ischemic papillary muscle dysfunction, generally that happens because of an MI, or infective endocarditis. So there are acute forms of mitral valve regurg and there are chronic forms. So we will cover the differences in the next few slides here. So because of the incomplete valve closure that we see with mitral valve regurg, there is blood that flows backward from the left ventricle into the left atrium. And both the left ventricle and left atrium have to work harder to maintain cardiac output. So like I said in the previous slide, there's both of the acute and chronic forms of mitral valve regurg depending on the cause. So for example, if I had a massive MI and it damaged the structures that are holding that valve in place, it would be an acute mitral regurg. Whereas something that happened over time, such as rheumatic heart disease or even the mitral valve prolapse, I would have the chronic form. So something that would happen, not acutely, but over time. So with the acute mitral regurg, I would get flash pulmonary edema because of the heart failure that would come along with that mitral valve regurg. And in the chronic form, I would have the ability, or my heart would have the ability to compensate for the, for my decreased cardiac output. So I would have both left atrial and left ventricle hypertrophy or enlargement to try to make up or try to preserve that cardiac output. That clearly doesn't happen in acute form because I don't have enough time to do that. So this is just a picture, so you can see that the left ventricle and left atrium are both overwhelmed and have increased volumes. So our acute form of mitral regurg, again, possibly due to an MI, patients will have very low cardiac output. So our symptoms, such as the thready peripheral pulses, clammy extremities, will be secondary to a low cardiac output. Many times patients with acute MR need a cardiac cath to repair the valves, and depending on the structures that are affected, depends on whether they can just go to the cath lab and have repair of some of those valve structures, or if they'll need a valve replacement. In our chronic form of mitral regurg, again, our heart is compensating over time. So patients are asymptomatic for years because our heart is able to change to maintain our cardiac output. Over time, when symptoms do start to present, they will have weakness, fatigue, palpitations, progressive dyspnea, all related to our left ventricular heart failure because now I have hypertrophy. At some point, usually these patients need a valve replacement. They are at risk for left ventricular heart failure and or pulmonary hypertension. So getting a valve replacement before we have, a really progressive form of left ventricular heart failure or pulmonary edema is best. So mitral valve prolapse is the most common form of valvular heart disease in the United States. And it happens because the valve leaflets actually buckle back up into the left atrium during systole. So that forces blood from the left ventricle to be pushed back up into the left atrium. So mitral valve prolapse is a form of mitral valve regurg. So regurgitation happens with the prolapse. It's just something that happens that's different. So there is some genetic link that is obviously linked to the mitral valve prolapse. But unfortunately, there are many cases where we don't know why somebody has mitral valve prolapse. So There's still research that needs to be done that is not completed. So we confirm mitral valve prolapse with an echo, again, because we can see those valves kind of buckle back up into the left atrium, and they can also see the regurgitation of blood going from the left ventricle up into the left atrium. Many patients, most actually, are asymptomatic for life. So even though it's one of the most common valvular heart defects, fortunately, many of those patients don't even know that they have mitral valve prolapse. There's only a very small percentage that actually have symptoms. It's often diagnosed because healthcare providers hear a murmur, and then they undergo further testing to determine why that murmur is present. So they'll have an echo, and then mitral valve prolapse is kind of determined from there. For those patients who do have symptoms, the very small amount, the most common symptoms are dysrhythmias, either a PSVT, SVT, or some PVCs. So they can cause palpitations, lightheadedness, and dizziness. They also have some chest pain that does not respond well to nitrates. Not quite sure why this chest pain occurs in people with the mitral valve prolapse. Maybe secondary to emotional stress, but they're not quite sure. Beta blockers are the medication of choice to treat the PSVT, the PVCs, and the ventricular tachycardia in these patients, and then valvular heart surgery as well to really correct again, in the small percentage, to correct the symptoms related to mitral regurg from the prolapse. So patients do need antibiotic prophylaxis to help prevent against IE, which is common. Taking medications as prescribed, such as the beta blockers, they really want to avoid dehydration and avoid stimulants, which can, stimulants can lead to increased PVCs, a PSVT. So we really encourage a healthy diet and exercise without the use of stimulants. So when to call the healthcare provider would be if symptoms worsen. So excessive fatigue, shortness of breath, especially without any exertion, anxiety and palpitations would be reasons to call the healthcare provider. And moving on to aortic valve stenosis. So many times this is congenital, or if it is seen in older adults, it is related to degeneration or due to untreated rheumatic fever. But again, we really don't see rheumatic fever that much anymore because we have fabulous antibiotics. So what's going on in the heart? So with aortic valve stenosis, there is an obstruction of blood flow from the left ventricle out through the aorta. So the left ventricle has to work extra hard to push blood out through that stenosed aortic valve. So to overcome this, the left ventricle winds up beefing up, and this causes left ventricular hypertrophy. And we all know that with hypertrophy and an enlarged muscle, it consumes more oxygen. Consumption of that myocardial oxygen happens because of the increased muscle mass, and then over time this leads to a decrease in cardiac output because that left ventricle hypertrophy can only work for so long, and then it doesn't become as useful as it was. Blood backs up from the left ventricle into the left atrium and therefore the pulmonary system, and we wind up in left ventricular heart failure. So some of the symptoms that we see with aortic valve stenosis are angina, and this happens because our coronary circulation branches off of the aorta after the aortic valve. So if our aortic valve is stenosed, not only do we have a decreased cardiac output, but that decreased cardiac output, we're not getting blood to our coronary artery circulation as well. So hence the angina. We get syncope and exertional dyspnea, again, because of our decreased cardiac output. So this is like the triad that we see with aortic valve stenosis. You also get some oscillatory findings or differences. So you get a very prominent S4, which is a gallop. So you will hear an atrial gallop. Systolic murmur, and normal to soft S1, which is our tricuspid and mitral valve closures. So you do get some different heart sounds. Patients don't actually get symptoms of aortic valve stenosis, like that triad we just saw, until the valve opening is about 1/3 of its size, which is crazy to think about. So our body compensates pretty well, actually. So there's a very poor prognosis if they're symptomatic and it's not corrected. These patients who do present with severe aortic valve stenosis are, asking for a valve replacement because that's what they need. We do use nitroglycerin very cautiously. So nitro could be used because we want to dilate those coronary arteries to allow for more oxygen and blood to get to the myocardium, but we also use it very cautiously because we already have a decreased cardiac output. We already have a decreased afterload. So we really want to be very cautious with nitroglycerin use. Just like with mitral valve regurgitation, we have an acute and chronic forms. With aortic valve regurgitation, we also have acute and chronic forms. So acute forms clearly happen very suddenly. This could be from IE, it could be from trauma, or it could be from aortic dissection. It's a life-threatening emergency, and valve replacement or fixture needs to be done immediately. And then there's chronic aortic regurgitation, which we see with the following conditions. So what's going on in the heart with aortic valve regurgitation? Well, there's a backward of blood flow from the ascending aorta into the left ventricle, which would lead to a decrease in cardiac output. With the chronic forms of aortic regurgitation, our heart would try to compensate for this with the left ventricle beefing up, hypertrophy, and dilating to hopefully increase the amount of cardiac output. Over time, this decreases my myocardial contractility and my compensatory mechanisms no longer work, and I wind up with pulmonary edema, right? That blood is backed up into my left atrium and then my pulmonary system. So I wind up with pulmonary hypertension and then eventually right-sided right ventricular heart failure, right-sided heart failure caused from my pulmonary hypertension, right? Because we learned in heart failure that a lot of times left-sided heart failure can cause right-sided heart failure. So this is one of those instances. Patients with the acute form of aortic regurgitation will have a severe decline in cardiac output and eventually wind up in cardiogenic shock, which is the left ventricle just kind of craps out and it's unable to maintain cardiac output. And those are some of the symptoms that we wind up getting. Like many chronic forms, chronic aortic valve regurgitation, patients are asymptomatic for years because our heart is able to compensate for that regurgitation. As those compensatory mechanisms start to decline or no longer work as effectively, some of the symptoms that we get is exertional dyspnea, orthopnea, and PND, which is that paroxysmal nocturnal dyspnea. Angina can happen, although we normally see chest pain more with aortic stenosis. And then we get this water hammer pulse, which is a really strong, quick beat that winds up diminishing fast. And then we'll get this really strong, quick beat, when we're palpating the pulse, and then it will diminish. So that's called a water hammer pulse, and it's specific to aortic valve regurg. So we don't really see a lot of tricuspid and pulmonic valve issues. So much of your focus should be placed on our mitral and aortic valves, since those are the valves that are primarily affected and that we see most in the clinical setting. But we are going to cover the right side of the heart as well. So tricuspid valve stenosis occurs in patients mainly with rheumatic heart disease and IV drug abuse. And that IV drug abuse stems from the IE that we would see with that. So in tricuspid valve stenosis, we get right atrial enlargement, right? Because that right atria is trying to push blood into the right ventricle, but because there's such a small opening, it's unable to. So it enlarges to try to compensate for not only the increased volume, but to help push that blood into the right ventricle. So we wind up getting a backup of blood into our systemic circulation because our right atrium is fluid volume overloaded. So our clinical manifestations would be very similar to right-sided heart failure. Pulmonic stenosis is almost always congenital. And again, we see this in the tetralogy of Fallot, which we talked about with the congenital heart disease. So it can cause, pulmonic valve stenosis can cause right ventricular hypertension and hypertrophy. And we wound up with clinical manifestations of fatigue and a very loud murmur. So some of the diagnostic studies are listed below. So of course we always want to get a history and physical exam to see if there's anything else going on. CT scan of the chest, this is to rule out any other complications that could be going on, such as aortic disease. An echo, specifically a TEE, to see if there is a history of IE or to see if there's any vegetation that is causing the valve disease. Chest x-ray, ECG, and then cardiac cath, because then we can determine the different pressures on the heart if there is some degree of stenosis. So not all forms of valvular disease will require surgery. Sometimes we treat them very conservatively. It depends on the patient's comorbidities and so forth. And it also depends on the valve involved and the disease severity. So our main goal is really just to prevent heart failure exacerbations and complications related to that valve disease. And that really drives providers to determine whether or not they need surgical intervention. So with the conservative management, some of the medications that will be used are the medications to treat and control heart failure, which we've already gone over. Sodium restriction, again, that's to treat the hypertension and to control heart failure. Anticoagulation therapy would be necessary for dysrhythmias, specifically atrial fibrillation that is common with some of the valvular heart disease, and then any antidysrhythmics as well. So one of the procedures specifically for stenosis is a percutaneous transluminal balloon valvuloplasty, which is done in the cardiac cath lab. So they thread a catheter usually through your femoral artery, and they thread that up to the stenosed valve, and then they inflate this balloon to separate the valve leaflet. So it's to help open that valve more for stenosis. So there's a picture of what that looks like on the next slide. So this is a picture of the percutaneous transluminal balloon valvuloplasty procedure. So there's 3 different pictures, and each of them is a different type of balloon that can be used depending on the degree of stenosis. Some patients might benefit from valve repair and not from a total replacement. And this really depends on the degree of heart failure, or the symptoms, and the patient's clinical state and comorbidities. So on the next slide, we'll talk about the different types of valve repair that can be done, and then we'll talk about the valve replacements, which we'll spend more time on. So these are some of the different valve repair surgeries that you might come across in the clinical setting. So the valve repair can be as invasive as open heart surgery to replace that or to repair that valve, or it could be minimally invasive, which can be done by robotic surgery, and they literally suture some of the torn leaflets like they do in the valvuloplasty. So for valve replacement, which we'll spend a little bit more time on, there's 2 types of valve replacements. We can have a mechanical valve or a biologic valve. So the mechanical valves are more durable and they last longer. They can actually last upwards of 25 years, and sometimes, in younger individuals, it can last for the rest of their life, so they don't need to worry about having another valve replacement. The downside of a mechanical valve is that it requires long-term anticoagulation with warfarin only. So no Eliquis, no Xarelto, it has to be warfarin. So biologic valves do not last as long. They're still prone to degeneration. The leaflets can stiffen just like a regular valve can. And they don't last as long. They only last about 10 to 20 years. However, there's no anticoagulation required like there is with the mechanical valve. So we don't have to follow specific dietary considerations. So this is just a picture of some of the prosthetic valves and what they look like. Of course, it doesn't do any justice because we can't compare it to anything, but here we are. So for our nursing assessment, gathering some subjective data about their past medical history, including, whether or not they've had rheumatic fever, infective endocarditis, looking to see if they've had any congenital defects, MI, any sort of chest trauma, etc. IV drug abuse, which is the IVDA, fatigue, and then some of the other symptoms that would make us believe that their valve was causing some sort of, some other problems, either heart failure symptoms or assessments specific to that valve dysfunction. Our objective data, determining whether or not they have a fever, again, because IE. And then the other 2 bullet points are our heart failure symptoms that we would be likely to see if we did have a deficient valve. So for our objective data, we could listen for any murmurs that we heard or any extra heart sounds, assessing for dysrhythmias that were not present before, especially our AFib. And then our other symptoms, again, relate to heart failure and the degree of heart failure because of that valve. So our goals with these patients are normal cardiac function, right? We want to keep them out of heart failure. Improving activity intolerance, since many of our valve diseases have some degree of activity intolerance. And then understanding the disease process and health maintenance measures, such as making sure that they take prophylactic antibiotics, right? Because now that they have an artificial valve, if they do, or if they have any valve complications, this puts you in that IE risk factor category. They also need to be compliant with their medications, and that would include if they're on warfarin because they have a mechanical valve. They would need to check their INR levels, which they need to be 2.5 to 3.5 for a mechanical valve, and also follow proper dietary restrictions. For our health promotion, diagnosing and treating our strep infections, right? Because we don't want patients with rheumatic fever, rheumatic heart disease from treatable strep infections. Prophylactic antibiotics for patients with a history. So anybody who has valve problems, especially those who have had surgical interventions with their valves, are at risk now for IE, so they do need to have prophylactic antibiotics. Encouraging compliance with medications and with activity restriction, and then teaching the patient when to seek medical treatment, which would be heart failure symptoms, right? Exacerbation of those symptoms. We do want to teach patients to avoid activity that causes excessive stress and fatigue. So nursing school would not be for these people. I'm just kidding. Discouraging tobacco use, because this does have excessive effects on the heart, such as hypertension, decreased oxygen levels in the blood. So I don't think smoking tobacco is good in any circumstance. Ongoing cardiac assessments to monitor drug effectiveness. So those are those medications to prevent or treat heart failure, and then monitoring our INR, which again needs to be between 2.5 and 3.5. We do need to do a lot of teaching, such as drug actions, when to take them, why they are taking them to increase the compliance, the importance of prophylactic antibiotic therapy, and to carry around a card so that way they can notify medical care personnel that they do have a valve or a valve issue, valve disease, and possibly even wearing a medical alert bracelet. So again, we know that patients do have valve disease, so they can get proper treatment even for simple procedures such as going to the dentist. So that sums up our valves. I would encourage you to, there's a Word document that is also under the PowerPoint section that I would encourage you to look at. It just reinforces some of the points that have been presented in this PowerPoint.